spoken, I know. If you can't hear me, just let me know. I'll try to speak louder. My presentation is going to be about the diagnosis of ectopic pregnancy, so I didn't know that there was going to be one already, but this is going to be more about, this is more like bread and butter, like the diagnosis, what you should see on ultrasound, and management. So we're going to start with the case. How this is going to work is highly dependent on you guys helping with being interactive, so help me out. So starting with the case.
Is there that cookie thing? Damn it.
It's not doing anything. Like it's working on mine, but it's not working on the monitor.
Robbie? I don't know how to use a computer. Oh, Dr. Wilson.
Yeah.
What'd she say?
Hope you two are enjoying this.
She knows. God damn it. I can send one as a to throw things off.
Oh, there we go. Now it's big. Okay, so here's the case. You have a 19-year-old P0G0 presenting with bilateral lower quadrant pain and vaginal bleeding for 2 days. What do you want to know?
What does she look like? Vitals.
Yeah, she's talking to you. She's just saying, you know, I have some belly pain. It's been going on for the past 2 days.
What was her last menstrual period?
9 weeks ago.
She's sexually active?
Yes.
Has she beaten the cup yet?
That is actually very true.
Yes, you have some great triage nurses, and they got urine on her already.
Is the stat lab open?
Stat lab is open, yes.
The urine is negative?
What is it?
You got any urine?
Yes. Your UPreg is positive.
Does she know she's pregnant?
She doesn't know she's pregnant.
Okay.
Sexual history?
Sexually active with one partner. History of chlamydia 2 years ago was successfully treated.
Vaginal discharge this time.
No vaginal discharge, just vaginal bleeding.
Quantity of bleeding?
What is it?
Quantity of blood?
She says she's kind of like a normal period, filling out a pad every 4 hours.
Any like cysts or fibroids?
What is it?
Any history of ovarian
No
cysts?
history of fibroids.
How bad was her chlamydia infection? Was it like asymptomatic, so full on PID?
No PID. She was just told she had a little bit of belly pain, and she had vaginal discharge, positive for chlamydia, and was treated. And repeat test was negative.
She like tolerating keto?
She said that she's had several episodes of non-bloody, non-bilious emesis today.
So what made her come in if it like is normal or is like a period and she's having pain?
She said usually her periods are not, the pain is worse today than it's been for her normal periods. And she's vomiting.
Any passage of like tissue or anything?
Nope, just blood.
When was her last period?
9 weeks ago.
Does she have a history of her regular period?
No, pretty regular.
Does she have any like dysuria?
She denies any urinary symptoms. Yep. Anything else under your systems?
Any recent trauma?
She denies any traumas. She also denies any fevers, no chills, no back pain.
Shortness of breath?
What is it?
Shortness of breath?
No, denies shortness.
Dizziness?
Denies that. Good question. So that's your positive review systems, nausea and emesis, denies fever, no diarrhea, no urinary symptoms. That's a GYN history. LMP was 9 weeks ago. Like I said, history of chlamydia treated 2 years ago. And this is what your exam looks like. So her vitals are pretty stable. She's afebrile, blood pressure's normal. She's not tachycardic. She's siding well. general appearance, in mild distress because of pain, but otherwise she's well appearing. Positive, pertinent positive on the exam. She's tended to palpation on the bilateral lower quadrant with guarding on the left lower quadrant. No CVA tenderness. Uropelvic exam, you see scant blood. The cervix is closed, but you see a little bit of blood in the external os. Your bimanual exam, she has CMT and left agnesal tenderness. So at this point, what's your differential diagnosis?
TOA.
TOA, it's good.
Ectopic.
An ectopic.
PID.
Torsion.
PID, torsion. Great. What?
Spontaneous AB.
SAB, threatened SAB, I can hear. You said something?
Threatened versus spontaneous.
Oh, okay, spontaneous, okay, great. Those are pretty much everything that I had there. Ectopic, plus or minus rupture, spontaneous or threatened AB. Appendicitis is a good one to think about. TOA or PID and ovarian torsion. So, what's your workup going to be like for this patient? Like, what do you want to order? What do you want to do?
So,
Good. Type and screen.
CBC.
CBC, CMP.
first
Why a
thing-
CMP instead of a BMP?
I'm sorry?
LFT is great. Anything else? So I heard CBC, CMP, beta HCG, type and screen, pelvic ultrasound.
Yeah, the
Good.
first thing I would do is put a transabdominal probe
Right.
in this person before
Exactly.
even going to the transvaginal.
Yep.
Because if you see an IUP,
Good.
then you're done.
Great. So I put transvaginal ultrasound, but as you heard earlier, transabdominal ultrasound is also something that you need to do in this patient. So that's your labs. Your preg is positive. HCG is 1500. H&H of 12 and 34. CMP is normal, and this is what you see in your transvaginal ultrasound. What do you guys see here? It's already it's already on the picture, but it's a uterus, and of course it's empty. You don't see anything in the cavity. And then it's doing that same thing where it's like
So
it's
an
playing here, but it's not playing.
it's an extended stop, so move the mouse off the screen. It's not mirrored.
It's not your. So you do your transvaginal ultrasound, and this is what you see. Sorry. So you can see a little bit of ovary here. This is the left side. A little bit of ovary. The uterus apparently is supposed to be here, and this is your left appendix.
Hold the circle.
So your diagnosis is an ectopic pregnancy. What things do you not see on ultrasound, like things that would make you worried if you saw it on this ultrasound? Free fluid, good. What if I saw what looks like a gestational sac in the uterus? What would that, is that an IUP? If you saw what looks like a gestational sac in the uterus? Right, exactly. Probably a pseudosac, unless you have a double residual sign, which is you see the yolk sac and the gestational sac in the uterus. You can't necessarily diagnose that as an IUP. So now we're just gonna talk about like the bread and butter of ectopic pregnancy. I'm just gonna have you guys take some guesses. What are the most common presenting symptoms of an ectopic? Pain, bleeding. Which one do you think is more common? Pain. That's what I thought too. But apparently, first trimester vaginal bleeding. This was a retrospective study back in 2009. It was like 376 ectopic pregnancies, and out of all of them, the most common presenting symptom was vaginal bleeding. That was 76% of them. The second one is pain. And then the third one is like normal pregnancy symptoms and signs like amenorrhea, nausea, vomiting, fatigue. And the most common location. This was already talked about earlier, so hopefully you guys know this. What's the most common location? The ampulla, exactly. I tried to look into why that's the case. Do you guys know why the ampulla is like the most common location? Yeah, me neither. I read a lot of different things and it wasn't really, I read something about, so fertilization happens mostly at the ampulla, and with ectopic pregnancy, a lot of the time the problem is migration issue. So the fertilized egg has trouble moving through the tube, so it just stays at the ampulla where it's fertilized. Then that's the reason why it's the most common location. What's the second most common location for ectopics? I heard you say it. Cervix. Oh, I didn't. That's not it. I heard something else. Any other guesses? It's the ovary. So one is the fallopian tube, 96% of the time, with the ampulla 75% of the time. The ovaries are actually the second most common location, and then the third one is interstitial. Last one being abdominal. I actually saw an article about an ectopic pregnancy in the liver. That was kind of interesting. But yeah, it happens. So we've already touched on this as far as like the diagnosis or what you see on ultrasound with ectopics. So an empty uterus with an absent yolk sac and fetal pole, you may see a pseudosac. Adnexal mass on transvaginal ultrasound, if you see free fluid in the cul-de-sac. So the cul-de-sac is like the area or the little pouch. Anterior, it's between the bladder and the uterus, and then posteriorly, it's between the uterus and the rectum. If you see free fluid there, probably an ectopic pregnancy and most likely a children. And obviously, if you see a yolk sac or something in the fallopian tube, or cardiac activity in the adnexa, as we saw earlier. So how do you evaluate these patients? Like, what's the most important thing that you need to do for these patients to evaluate them? Like, what do you need? Start with. What? Vital signs, ABCs. So start with your ABCs. Is your patient hemodynamically stable or no? So I made this little chart. It's super simple to go through. So starting with if your patient is unstable, so if they just don't look well, showing signs of shock, in order for the patient to be hypotensive, that means they probably bled quite a little bit into the abdomen or into the pelvis. So start with your ABCs, IVO2 monitor, and do a fast exam. Even if you don't know whether or not this patient's pregnant, and you see free fluid in Marsden's pouch, that basically, and there's like no signs of trauma, this patient didn't have any trauma, young woman of reproductive age, an ectopic pregnancy should be very highly differential. So once you do this initial things, you need to resuscitate the patient. This would be a good time to activate the massive transfusion protocol because, like I said, in order for your patient to be like really hypotensive from this, that means they lost quite a bit of blood. And then you need immediate surgical consult, so consult your OB-GYN. Don't delay that from just trying to do everything else, trying to do a transvaginal or transabdominal ultrasound. Immediately consult OB-GYN. What if your patient's stable? So in that case, you can get labs, you can do your fast, you can do your transabdominal and transvaginal ultrasounds. And then from there, if your patient's stable and they are a methotrexate candidate, which I will talk about later, then you can consult. You still have to consult OB. I'm not sure how it works here as far as methotrexate. Like, do we give it or do they have to go to OB?
Yeah, that's our research.
I'm sorry.
There's recently some stuff that's been changing around, I think Monday through Fridays, 8 to 5, right? It's, we can order it, and OB-GYN puts in the order and pharmacy gives it, but other than that, we need to transfer the patient out.
Oh, I see.
There are those emails about it recently.
Does downstate administer methotrexate all the time?
Downstate? I'm not. That's why
I don't remember what they said about that.
The thing with downstate is that the
They were
doctors
transferring to
don't
downstate
stay.
because
Oh,
of
so they
that.
just
So-
get admitted.
Well, or they get evaluated in OB triage,
Okay,
all
so
pregnant
they'll-
patients, for the most part. So GYN gives it.
Okay.
And there's a pharmacy issue recently, that's what the recent controversy is, but classically, GYN gives it as well.
And if this happens in county, they have to be transferred to.
Only if it's
This
like
is just a recent
It's
pharmacy.
after you get
Yeah,
it at nighttime,
yeah.
and that's like in the last like couple of weeks.
Yeah.
Alright, good to know. So if they're a methotrexate candidate, then they get methotrexate with several HCGs. Of course, like that's like, I guess not in our scope. OB does that. If they're not a methotrexate candidate, then you need surgical consult. So either way, OB is going to be involved. So let's just talk about quickly who's a candidate and who's not. I know that's a lot, just like ignore that for now. So in order for you to be able to administer methotrexate to these candidates, one, they have to be hemodynamically stable. They also have, it has to be an unruptured pregnancy, ectopic pregnancy. If it's ruptured, of course they immediately go to the OR because that's a surgical emergency. What is that? Oh, the HC. These are all. I got this from ACOG. These are all the ACOG recommendations. The HCG levels need to be less than 5,000. And then the last one is there are no absolute contraindications. So the absolute contraindications is all of that. If you have an IUP, like a heterotopic pregnancy, you can't do methotrexate, obviously. If the patient's breastfeeding, like I said, if it's ruptured, hemodynamically unstable. Actually, this was kind of weird. Active peptic ulcer disease. So these are all the things that you need. This is why it's really good to get a history from your patient to figure out whether or not. If they have active peptic ulcer disease, you can't give methotrexate. Or if they have liver disease, which is the reason why you need to get a CMP at the beginning. If they have elevated liver enzymes, it's a contraindication for giving methotrexate. And another thing that I just kind of wanted to like hammer in, as was talked about earlier, if your patient has like an HCG of 800, you know, a lot of people are like, that's not in the discriminatory zone for getting a transvaginal ultrasound. You still should, especially if they're having really bad abdominal pain, a little bit of vaginal bleeding. Get an ultrasound because if an ectopic pregnancy is, for example, in the isthmus, which is not as expandable, it tends to rupture a lot quicker than it would if it was in the ampulla that's like a lot bigger and able to kind of expand. So if you have a patient that's got a HCG of 800 and you still do a transabdominal and transvaginal ultrasound, look for free fluid. Even if you don't see an ectopic anywhere and you see free fluid in the pelvis and a positive FAST, that's most likely an ruptured ectopic pregnancy and you just can't see it. I just wanted to thank Dr. Kendall in the back for helping me, Ray, who's not here, and also Ben. Do you guys have any questions? Awesome.
Back real quick to the ultrasound you guys doing the video. So, and I know this was touched on in the previous lecture as well. Please be thorough when you scan through pregnant patients. At a glance, to the untrained eye, sometimes a large ectopic can look like an IUP, and we've had at least one, if not more, terrible cases that we've missed in PV. And just to pass on a message from the ultrasound division, grab your attending anytime you're doing first trimester ultrasounds.
thing that a lot of times you're going to see actually is you'll have someone with just mild discomfort, ABCs are fine, you do your ultrasound, you don't see anything, but the beta ACG is positive, but it's low, and you don't see an ectopic or anything, and they're very stable, you don't see free fluid. What's going to often happen in those times is you're going to wind up discharging them to follow up in 2 days to get another beta and another ultrasound and to see GYN, and that's one of the most common things, because in that case, you're not sure if it's an ectopic or an early pregnancy. And so you have to follow them with good instructions. And always make sure, if you send someone like that home, make sure you have their right phone number on the chart. So, and follow them yourself. You can see if they show up in 2 days at GYN. If not, you call them.
Yeah, that's very important to have a reliable patient. If you feel like your patient isn't going to come back, they're never going to follow up, and your suspicion for an ectopic is pretty high, a consult will be maybe keep them in the obs or something. Same thing with methotrexate. There may be a good candidate, but you don't feel like they're a reliable patient, that's a contraindication to actually be with methotrexate, because you need to follow up with the HCG, make sure it's going down.
A normal pregnancy should double every 2 days,
Right.
roughly, the beta ACG. So if it's not, you got to worry even more as an ectopic.
Right.
Plus, you repeat your ultrasound and see if you're developing an IUP when it gets over the threshold, right? When it gets about 2,000, you should see something.
Right.
And if you don't, then you got to be more suspicious.
To that point too, I write their beta or I give